We'll start so we can, I'll try to be pretty succinct and try to stay in my time frame so we can actually all have our brown bag lunch. I'm Chuck Chabal. I'm a physician. I'm an anesthesiologist, pain management doc at Evergreen, although I worked for the University of Washington for about 20 years before I left and now in private practice. I was on the planning committee. I was asked by Alex to help plan this meeting, and somehow got stuck talking at the meeting too. So that shouldn't happen, but there you go. I'm going to talk about patient evaluation and risk screening, and I'm going to start out initially by playing a little video clip. When I was putting this talk together on risk screening and evaluation, a scene of a movie came out. It reminded me of a specific scene. And to give you a little bit of background, that movie is called Platoon. It was filmed in 1988, got a lot of Academy Awards, a lot of stars. In this clip, it's particularly starring Charlie Sheen. And as you say how art imitates life or life imitates art, in this movie, he starts out as a young, naive recruit in the military in Vietnam, and his life in the movie spirals somehow poorly out of control. And so it actually was a precursor of his real life. And the scenario here is Charlie Sheen's a new guy in the platoon, and they're out on ambush in the jungle. And this does tie into my talk, actually. And so they're out there, and they pair him with the most experienced guy in the platoon to do this watch. And they've set an ambush in the middle of the jungle at night. It's confusing, it's misty, it's dark, and Charlie Sheen wakes up and he sees the guy who's supposed to be on guard has fallen asleep. And I'll play this clip and we take a look at this. It's about a minute and a half. Well, The reason this came into mind is because these guys were tired. It's a confusing environment. They're busy. And the point of that is it's a dangerous world out there. And risk evaluating and screening, you need to be able to pick the dangers, the bumps in the road, and you need to systematically look at this. And so the law, I'll talk a little bit about the law. Well, I'll talk a lot about the law. And the law actually, I break it down into 3 points. So the law overview is you will evaluate and screen the patients. And Dr. Pattison went through a point-by-point view of how you do that and what you need to do. So you need to risk assess and evaluate. You need to document, and you need to reassess. One of the things I'll say about the document in the preamble to this law, which was a relatively late addition to the law, it said, it talks about the intent of the law, and one of the things it said specifically in its preamble is that when you're evaluating whether a provider is doing a good job or not, I'm paraphrasing things, it's not the amount of drug or how long they've been taking care of the patient. It actually goes back to how well that's documented. So documentation is a critical part of the new law, and the fact you need to reassess. You need to figure out, are you making these patients better or worse? And so the other thing, so in terms of why to do this law, I think there's really 2 broad reasons. One, it's the law and you need to do it. The second reason is I think it will contribute significantly to patient safety and quality of care. And after all, that's what we're in business to do. So again, I'll just go over the risk screening that you need to do. You need to look for history of addiction, abuse, aberrant behaviors, depression, anxiety, psychiatric conditions. This is, again, directly from the law. The use of benzodiazepines, alcohol, or CNS medications. Specifically, the central and nervous system depressants are a potentially very lethal combination with opioids. Adding on a small amount of sedatives can often tip people over the edge. Other things you need to assess for are risk for falls, sleep apnea, other opioid prescribers, pregnancy, emergency room visits, allergies. So when I look at how do you stratify and evaluate patients, I look at it in really at 2 levels. One is sort of the broad level from the law, and how do you do that? How do you do that to meet the fulfillment of the law and hopefully better quality care? And I also look at it as a clinical risk stratification. You know, translating that law to what does it look like in the clinic when you're in clinic every day. And I'll provide a little bit of a scheme here to go over this, how I do it, and I think you can look at it within your clinic. So when you look at patients in terms of risk stratification, what I talk about are patients with pain versus the chronic pain patients, or essentially the simple pain patient versus the complex pain patient. The simple pain patient is very much like this ad that ran for years in the back of the journal was an older guy that could, because he got drug XYZ, could now dance with his granddaughter at her wedding. That's laudable, that's wonderful. That's a simple pain patient. They actually get better. And don't laugh, it happens. They do get better. And I tell people that it's a wonderful thing if I don't see you again, because you do get better. The body heals, people recover. I mean, clinically, it's the patient with a herniated disc, some physical therapy, maybe rehab, maybe a steroid. They get better. That generally is not the kind of patient that gets to my clinic. And if you take care of a lot of pain patients, they don't, because there's a selection system there, right? If they get better, they're gone. They get better, they leave your clinic. The patients that don't get better are with you forever. And these are the complex pain patients. And these patients, clinically, what do they look like? And I think the reason you need to identify these patients is because these are the patients that bad things happen. It's not usually the simple pain patients that get into medication issues. What are the characteristics? Well, they functionally decline in spite of complex treatments. You try everything, you try different meds, they keep getting worse. They're often a diagnostic or therapeutic enigma. They don't get better. You do more tests, more consultations, they're not getting better. And many times, it's an unpleasant clinical interaction. They're not the kind of patient you actually are anxious to see. And I always look at my clinic and I look at the list of patients I'm going to see, and you can almost predict certain patients are going to be going well, and you know that'll be a slam dunk to see them in your allotted time. Other patients, you can almost predict these patients are going to take up as much time. You have to be very efficient with how you deal with those patients. And often the interactions are mutually unpleasant. They may not be totally satisfied with the care you're providing. You may not be satisfied with their progress. And they can often be demanding. They may be, in fact, drug-seeking. They're always asking for more medications and maybe some unrealistic goals. So if you look at what are the characteristics of their pain? Well, in these complex patients, long duration of pain, multiple pain locations, often a high pain severity. How many times you see patients, they come into my clinic, I go, well, can you give me an estimate of your pain level from 0 to 10? Or sometimes I say from 0 to infinity, the biggest number you can possibly make. And they say it's to infinity and beyond. And so that's the kind of assessment you get with these complex pain patients. And they're oftenly not very satisfied with the treatments you've offered, even though you may follow treatment guidelines. They're not happy with that. And so they're striving for more complex treatments, more medications, et cetera. So functionally, what do these patients look like? Well, they're not meeting responsibilities because of pain. And I always tell people everyone needs a job. And the job may not be something they go to Boeing and work, but they need to get out of bed and there needs to be a perfect purpose for life. Sometimes it's a hobby because they may be retired or they may be on disability, but it's a bad sign when these patients aren't doing anything. They're not interacting, they're not doing anything productive with their time. They're often not even doing some of the things that they have a responsibility for. Key functional tasks, housework, work around the house. They're not walking to the mailbox and getting the mail. They're often socially isolated and not doing anything. And if you test them, they almost always have low quality of life scales. These patients as a group are often depressed. They're generally unhappy. Sometimes they're a bit anxious. If you ask them, and we ask a scale in our clinic, where they think things are going in terms of their pain. Are they going to get better? Are they going to stabilize? These patients almost always say, inevitably, the pain's going to get worse. And with a science background, they've already said their pain is infinity. I kind of wonder, how's it going to get worse? But it, in fact, can get worse. And what they're largely talking about is not their pain, but they're talking about their suffering. Where they are in life and how unhappy they are because of their pain and a variety of other issues going on. Many of these patients, if you try to introduce a biopsychosocial approach, they're resistant to it. The other thing they're resistant to is often you'll tell people, they have an indication for an antidepressant or one of the newer non-opiate drugs. And I just had a patient yesterday. I said, well, you have fibromyalgia. There's some new drugs out. We should try these. And she said, I hope that's not an antidepressant classic drug. I go, what do you mean? She goes, I'm allergic to every antidepressant. I go, they also tell you things like, I don't want to be on these antidepressants because I hear you get hooked on them. Or they're really hard on your liver. You hear that stuff all the time. But yet, they're taking one of the other drugs that are clearly all metabolized through the liver. So in terms of therapeutic characteristics of these difficult, complex pain patients, they always want the next intervention or operation. A lot of them do, not everyone, but often they're looking for the cure. they often have a low interest in physical therapy or exercise. Or what you do even more so, you send them, they say, well, I've been to physical therapy 20 times. And you say, listen, you must have learned stuff. Do you actually exercise at home? Do you take 10 minutes? They don't do that. Or I try to do it and I'm in bed for the next 3 days. They have low interest in self-management strategies, and that they are at risk for iatrogenesis. I think these are the group of patients who you can get into trouble with pain medications. The three sort of things that stick out in these patients from a variety of studies are that, and as Mark Sullivan talked about, are a high incidence of mental health issues, depression, anxiety, DSM criteria, things like bipolar, often poorly treated, or they really don't have much active care. And it's interesting that Mark presented some of these studies. And I'll tell you, just as a little personal perspective, I've done pain management for a long time, and the tide has clearly shifted. 15 years ago or so, it was difficult to get an article published in some of the journals that didn't say opiates were highly effective in terms of pain management. And so if you published things or wrote articles that said, well, that's what you say, but clinically it doesn't appear, we're seeing problems, it was difficult getting published, some of those articles. That has actually changed significantly in recent years as we actually realize that there are some problems with opioids. The other thing in terms of, if he talked about these studies, there was an article probably 10 years ago in one of the pain journals, and they looked again at predictors of who would get opioids. Because interestingly, there's a paradox. If you look at all the guidelines, like say from the American Pain Society on providing opioids, one of the things they say right off the get-go is, you have to be used with caution or not at all patients who have a history of active depression or mental illness. But yet, as Dr. Sullivan pointed out in articles going 10 years, that's a high predictor of who in fact gets opioids, if you have mental illness or substance abuse history. So complex pain patients, mental health issues, substance abuse or alcohol, either active or past, and a high incidence of sexual abuse in many of these patients, which is a very difficult thing to ask. And we actually have patients. We will ask about that, but we also have forms that patients fill out where they discuss that. And there's some evidence that patients are more likely to disclose very sensitive information to a third party, or shall we say a testing instrument, than they are to some stranger who they just met in a physician's office. The other way, from a clinical point of view, in terms of evaluation and stratifying these patients, and this is sort of translating the law into clinical applications, is I look at these patients and try to figure out, again at a high level, are they seeking pain relief, which is what the normal human response. If you get hurt, you want pain relief. You break a leg, if you have a kidney stone, you want pain relief. And that's normal. The other group you need to figure out is that those seeking drugs, and I say that kind of in a broad sense, those seeking drugs because they may be self-medicating a mental health issue, depression, anxiety, a whole bunch of DSM criteria, diagnosis. There may be abusers, so these are patients, the other group are patients that are abusing. They're getting drugs from multiple physicians, they're scamming the system perhaps, and there's probably a very small minority, but it happens occasionally, patients I would call entrepreneurs that are probably selling the drug. And I say that because I do UDTs, and I think we're going to have a talk on UDTs later, urine drug toxicology screens. And occasionally, you get patients who you're prescribing drugs to, and there's not an evidence of any drug you're prescribing in their system. But yet, the other drugs, the medical marijuana is in their system. And when I tell people, I go, I'm giving you methadone, it's a massively long half-life, but it's not in your system. He said, well, it must not be my urine. I go, you mean the The one that we put the sticker over and you signed, and it does have the marijuana, so you wonder what the heck is going on with those drugs. And I think some of those patients, again, are very likely parlaying or selling those medications. There are classic stories about the elderly that they're brought in by younger family members, and the issue is you kind of wonder, are they really taking these drugs? Or, in fact, there are some case reports of family members actually bringing them in because they're selling or giving part of the drugs to the family, to the elder, but selling or using the medications themselves. So the law says you need to use a standardized instrument to do an assessment. And fortunately, I put a website, the Agency of Medical Directors of Washington, and I was on that agency directors group when we developed these guidelines. The agency has on their website suggestions and links to these. And there's a whole debate about if you're screening for opiates, do you use the opiate risk tool, the SOAP, the revised tool? Do you use something called the COM? And one of the whole limitations of this is, and the reason why you need to take these tests into context, is because these tests are not lie detectors. So patients lie, or they don't tell you the truth. And these tests rely on people telling you the truth. And there's a couple nuances about that. For most tests, if you supply a test to a patient and you say you're trying to assess disability on a disability exam, we have norms for these tests. So there's a problem if a patient takes a test and you're using some disability index and they endorse that they are several standard deviations worse than a group of patients who are wheelchair bound. You look at those results and you go, that's not consistent. And so there are, most of these tests that people do, there are filters, there are things in there to sort of catch people who over-endorse symptoms. However, when you're doing tests where the right answer you're looking for is normal or none, it's difficult to catch discrepancies in that. So you're not looking at patients who are more disabled, you're looking at patients who are not endorsing symptoms that they would. So it's hard to catch people by developing tests that you put tricks in saying these patients are probably not are not telling you the truth, or for whatever reason not answering accurately. The other thing is I use the ORT, and so the ORT is pretty well validated test. But I also go through medical history. I get stuff from the primary care physician. I get stuff on our online electronic medical record, and I see patients all the time who have been into say inpatient detox for alcohol, for some substance abuse history. But yet when I look at their intake, they're clean. Well, so what I want to say about this is you have to use a standardized instrument. I think it's a great tool. I find important, critical information about people all the time. But what I'm going to propose is that you need a clinical triad. You need standardized instruments, you need to look at clinical behaviors, and you need to do urine tox screens. In terms of behavioral profile, one of the things, when I worked at the VA, one of the psychologists said, you can use all these instruments, but one of the things that ultimately comes down to it is behaviors don't lie. If you have a substance abuse patient, ultimately the behaviors key them into that. And I'll say a few things about this from a clinical relevance too, is that I saw, we tend, when we look directly at the test, we can sometimes make, I think, terrible mistakes. I saw a patient in consult last week who was admitted for some abdominal pain. The patient's employed, he goes to work every day. He's on a tapering dose of morphine. When I saw him admitted, he had been taking 30 milligrams of morphine twice a day. which was down from 60 milligrams for 3 years ago. He's been on this for years at a time. When he came into the ER, the social worker admitted a screen to this guy. And she said, have you ever taken your opiates and then driven a motor vehicle afterwards? He said, of course, I go to work. And that bought him the label in his charts as an opiate abuser. Because when you look at the diagnostic criteria for substance abuse, that's one of the diagnostic criteria. I talked to the guy for 10 minutes. This guy was not a substance abuser. In fact, he was one of the opiate successes, I think, but yet got labeled. So life isn't as simple or straight as just testing. I think you need to do clinical context. You need to look at behaviors because, in fact, when you look at what is prescription opiate abuse, there's no great definition for that. What is misuse? And so is it because they have a day early refill? And so it becomes a little gray area. I would offer there are 5 behaviors that we use that I think indicate, together with standardized testing and UDTs, that you may have a problem patient. And those are issues that patients have a pattern of early refills. They're always calling in early. They have problems with medications. And the problems with medications are this. It was stolen. It was flushed down the toilet. I dropped all my pain meds and they went down the sink. In my view, that's a plumbing issue. It's not a medical issue. And I always want to say, I've never said this, but I always want to say, quit freaking and call Beacon. I don't say that. But it's these issues of patterns of stuff. Calling clinic staff, hassling the front office. And interestingly, we're setting up to do a second study, which we did. I'll talk about the first study. If you ask the nurses or people who answer the phone, they could almost always identify the patients that are giving you trouble, even though they've never talked to the patient. They're totally non-medical. It's because of the behaviors. Hassles in clinic, right? So they go in and they're always pushing for more meds. They don't want to talk about doing treatment planning and what the goals are. They want more meds. And the other sources of medication, so these are patients who are getting drugs from ERs, other docs, or in fact getting drugs from, they're borrowing drugs from their family. Again, any one of these are not necessarily diagnostic of having a problem, but if you have a pattern of these, it is a problem. We published an abstract here earlier this spring at the American Academy of Pain Medicine. I was one of the authors. Alex Kahana was one of the authors, and we looked at 2,300 patients who took a computer-based assessment, and then we compared a self-assessed index. So we asked patients, have you had early refills? Have you had problem with your meds? Have you had drugs lost? Have you been calling in the clinic? And what we found was, if you self-assess these patients, you ask these patients these questions, there's a very strong correlation between history of substance abuse, mental health issues, and questions on traditional tests like the opiate risk tool. So it's an interesting little correlation that these behaviors that they actually self-report correlate pretty well with other standardized testing. Again, one of the things in terms of evaluation and testing is you have to use the standardized testing, but that's not enough. I think you need what I would call the clinical safety triad, and that is you risk assess the patient using standardized instruments. You use UDTs, which I will not talk about because we have a whole talk on urine drug toxicologies. I have our own policy based on my understanding of the literature, but we use UDTs, not on every patient, but a lot of patients. And you have a behavioral index. Is the patient behaving like they've got problems? Those 3 things are a screen which I think you need to apply in clinic to sort of figure out what patients are at risk, what patients you need to spend more time with, what patients you may need to set very strict limits or even send out for consultation. What I would say, and I'm talking about just risk management, but this sort of blends into what I would call an opiate-specific risk management strategy. This is the strategy we use in our clinic, and it works like this. Every patient gets a written informed consent. It happens to contain all the 10 points of the new law, but we actually have some very specific, it's pretty comprehensive. We strive for 100% compliance, so I want to make sure every single patient using opiates gets that. When the patient comes in, I use that treatment agreement to talk to the patient about the new law and about what our clinic policies are and how that fits in with how we screen and treat patients. We use the validated screening, that is the validated measures that they take. We use urine tox screening on some patients. Part of the state law says you use a single pharmacy for controlled substances. We've interpreted that, rightly or wrongly, as every one of my patients who are on a controlled substance uses I picked a single pharmacy in town we use. They can get all their drugs from any other medication from other pharmacies. All my controlled substances go to a single pharmacy. That pharmacy actually has our treatment agreement in. And so they're on board as part of the treatment team of taking care of these patients. We use a behavioral index. If these patients are misbehaving by those hassling, problem with refills, we flag those patients. And we do follow-up reviews. We actually try to figure out, am I helping or hurting that patient? Has function improved? We use some standardized tests, but I also use some clinical things. Are they emptying the dishwasher? Are they helping with care with the kids? That sort of functional assessment that is often very patient-specific. And what I would say is, in terms to improve quality care, I would urge you to try to translate the law and the policy into better care. And so there are really three things. You have an opiate risk management strategy, and the second part of that is you be consistent with your behavior with these patients. For instance, I used to have patients who lost their meds or had a issue where they were stolen. I would give them 1 or 2 strikes. I now have 0 strike policy with that. Like I may not fire them, but I don't refill it. And I'm consistent across every patient. And I tell patients that's how it is. I also tell patients that that's my understanding of the law, that's my understanding of the medical literature, and that it's a gray area. They can find other providers that read the literature and think different than I do. And I'm happy to provide their names. They can go and get a second opinion. That's why you signed in, actually, today. The other thing I do is right up front with the agreement, I set reasonable pain expectations in terms of what I want to see in terms of function. And I've introduced this idea of this is a drug trial. We're going to try this medicine on you, and it's either going to work or not work. If it's not working, I'm not going to provide it. The things I provide with this are a couple things I talk about this. Again, my understanding from reading the literature is whether you're using tricyclics or non-steroidals or opiates in particular, you reduce pain about 20%, maybe 30% for chronically, not acute, chronically. And so I tell people that, listen, at best I'm going to do is 20% reduction. So if your pain's a 10/10, you may get an 8, you may get an 8.5, but you're not going to get a 4 and you're not going to get a 0. So I tell people that. And I'm very willing to remind them later when they say, my pain's only an 8, you need to get it down. Well, I can't get it down. And again, the other thing in terms of the triad of care is good documentation. Again, remember what the preamble says. Essentially, it doesn't matter what you do. Again, paraphrasing. It matters how you document it. So it doesn't matter that you have a long-standing treatment relationship with this patient. You better document that all the things it says in the law, that you've assessed the patient, that it's actually helping the patient, et cetera. And finally, my final question is, I hope this makes a difference. Will this law make a difference? And I actually hope it does. I think when State Attorney General McKenna talked about, it's a very difficult process to change things. And, they're doing things with education of kids. They're doing things with outreaches. And my concern about the limitations of the law, and I think it's largely a good thing, I'm not 100% sure, but I think it is this consultation business. as an anesthesiologist, when you had critically ill patients, I used to get a consult from the cardiologist or the internist before you take them to the operating room, and you would get a consult that said largely this: avoid hypoxia, avoid hypotension, and oh, by the way, don't let them bleed out during the operation. And so I said, yeah, that's a very useful consult. And if they're right, but so taking care of somebody, I go, that doesn't help me. And that's one of the things I worry about, that we don't have the anesthesia equivalent of the consultation with these patients. That in fact these consults actually improve quality of care. And the final thing I will say is, as Dr. Sullivan, remember he talked about that bell-shaped curve of patients, a lot of patients who were using a lot of opiates got into trouble, or the tail end that were using a lot of opiates, but there weren't a lot of patients. I've learned about a number of cases in the community of patients who've gotten into trouble with opiates. And one of the things that struck me in these cases is these were not patients that were at the tail end. These were not patients that you would have thought that were getting multiple drugs from people. They were not the patients that you would have that you would have said, listen, this patient is a big problem. I've got to watch them. And so one of the things, I think this prevents an opportunity, is we look at deaths and bad outcomes in the community, is to look at that data a little closer in this state, which is actually a lot of work. And figuring out some of these patients, you have the classic polysubstance abuser who's overdoses, but there are also patients that are not polysubstance abuser that overdose. And take a very, very closer look at that. I think it provides an opportunity as we go on to sort of take a look at those patients and see where there are risk factors that we missed. Thank you.